Ladies and gentlemen, welcome to Thrivecast. This is Stuart Joseph, and I'm joined as always with my good friend, Mr. Nathan Ash. Nathan, who do we got in studio today?
We have Mr. Charles Wilson, Dr. Charles Wilson.
No, just Mr. Charles.
Mr. Oh, okay. Sorry.
Social worker by training.
Social work. Okay. Well, I don't think we give ourselves enough credit as social workers. Executive Director of the Chadwick Center, part of Rady's Children's Hospital here in San Diego. So, Mr. Wilson, how are you doing, and kind of what are your initiatives that you'd like to educate our audience on today? We talked a little bit in the prelim.
Well, direct, as you said, something called the Chadwick Center, but also have responsibility for broader mental health types of services at Rady Children's Hospital. So we got a lot of initiatives. We have programs at the Chadwick Center that focus on children who have been abused or exposed to violence, who have some degree of suffering the after effects of traumatic stress. So we have physicians who are the child abuse specialists in San Diego who work with those children, help assess what may have happened to them, ensure they have proper treatment. We do the sexual assault exams for children who may have been sexually abused. We also have people who specialize in talking to kids about what they may have seen or happened to them. So if the police think a child may have been sexually abused or witnessed a homicide, particularly younger children, they'll bring them to us, and we have people whose only job is to talk to kids. And they do it in 5-year-old, and they can do it in 17-year-old.
For our listeners who don't know, what is trauma?
Well, trauma is one of the other things I do, and actually I can, let me frame it a little, and then I'll answer that question.
Please.
It's kind of a key issue for us. Is we also began a mental health program back in the 1980s when we were seeing all these abused children who had traumatic stress issues. Very extreme events happened to them that overwhelmed their capacity to cope. That left them with nightmares, with intrusive thoughts. They couldn't get the images out of their head. Yeah. Left them with anxiety and fear of places, people, things. And the mental health community in the late 1980s and 1990s didn't think that was a mental health problem. They said child abuse is a social problem.
Or a legal problem.
Right. And when Dr. Chadwick, who's the center's named after, when he couldn't find mental health people who seemed to care enough about this issue, he decided to start our own program at the hospital, and that became our largest program. It's called trauma counseling. That led us into a very major role across the country. So there's something called the National Child Traumatic Stress Network. For any of your listeners who are interested in really understanding about trauma, particularly in childhood, it's the National Child Traumatic Stress Network, the ntsn.org. And there is a ton of resources on that. The National Child Traumatic Stress Network was set up by Congress ironically, they set up in 2000, and in September 2001, they were reviewing the proposals when 9/11 happened.
Wow.
And the whole issue of childhood trauma, the children who were in the daycare centers who saw people falling from the Twin Towers, was on everyone's mind. And so Congress really then, over the next couple of years, built up this National Child Traumatic Stress Network.
I could imagine at that time there was a major need in all communities for that.
Particularly in the New York area. But it was kind of at the beginning of that week, child abuse was the prominent form of trauma people were talking about, or witnessing violence. By the end of the week, it was terrorism.
Yeah.
Now, quite frankly, child abuse and witnessing violence has remained the primary causes of trauma in childhood right now. But along the way, we've recognized there's a lot in common between what happens physiologically and emotional and psychologically for a child in child abuse with what happens if they're caught in a tornado, right, or in a flood, or a Katrina, or the tidal waves in Japan, or what happens in a school shooting.
Yeah.
And so this notion of really understanding traumatic stress plays out. So trauma is really defined as, it has 3 elements. There's an event. There's an event like an abuse incident, like a shooting, like a tornado. Something happens. There's the experience that person has. It's called the 3 years. Okay. So we all watch 9/11 happen on television, but the people closest to it were much more affected. Yeah. So how you experience the trauma differs. For me, that was really exemplified in when the tsunamis hit Japan, which I think is 2009 or 10,
Yeah.
somewhere in there. I was actually waking up in Florida outside of Orlando, getting ready to deliver a plenary address to a group of professionals about childhood trauma and what we call trauma-informed systems, how systems can learn how to be more effective working with traumatized children and adults, and how not to make it worse, or at least minimize making it worse. And I turned on the TV and I saw these horrific images that we all saw of the flood coming and the cars driving, and it was just horrible images. And I was struck with that. And then as I was getting ready to go downstairs to do the speech, they said they'd issue tsunami warnings for the west coast of the United States.
I remember that, yeah.
Now, at the time, the image I had was this 20 and 30-foot wall of water rolling miles inland.
Yeah.
And an untold disaster. Well, it was 7 o'clock in the morning in Florida time. It was 4 o'clock in the morning here, or more personally for me, in Santa Cruz, where my daughter was a student and living a block from the beach. And so I couldn't, she was sleeping through the phone ringing. So I envisioned that tidal wave coming and her oblivious, and I had to turn around and talk about trauma to everybody else.
Yeah.
But for me, that experience was much different than watching 9/11, where as far as I knew, at that point, I wasn't personally as involved as I was in the
But with
tsunami.
your daughter in Santa Cruz,
Or
it
personally
kinda
involved when their children are abused, or when their siblings are abused, or they witness domestic violence. So it's the event, but it's also how it affects that person.
Yeah.
And then it's, in effect, the impact of it, or the experience, how they experience it, and then it's the effect of it, it's the impact. Because of there's natural resiliency in kids, and adults too, sometimes bad things happen, but they bounce right back for it. But for a lot of us, you don't bounce right back, and so it's the impact. We were talking a little bit before the break. I mean, there's research right here in San Diego, that it's called the Adverse Childhood Experiences Study, that the Centers for Disease Control have been doing here for years with Kaiser patients. But they can, if you had, and I'm going from memory because I didn't come planning to talk about the ACE study,
But the ACE study, right.
I think if you have 4 different types of adverse experiences in childhood, and it may be 6, but I think it's 4. If you have 4 or more, your life expectancy is reduced by 20 years. People die in their 50s and 60s rather than their 70s, 80s, and 90s because what happened to them when they were 5.
Right.
And so we know trauma has this huge lifelong effect. So
And we're seeing that, and I've talked about this on the show, is that we can see the genetic imprint of trauma. And by, again, part of me at times, and I've advocated this, is why can't we, when we talk about a single mother, maybe she's receiving assistance. Well, she needs to work. The societal benefit of her staying home and raising her kids has a much significantly more cost benefit for society, because we can prevent those traumas a lot of time, or the potential for it, and give proper empathy and love and development for that kid, or for those children. But we don't look at the data. We look at things in this superficial rule of thumb type way of how we deal with it. And yet you see it every day of there needs to be more understanding of the data and how we can respond to it. I mean, the ACE study has it's involved over 17,000 different participants.
Right.
And the levels are adverse child experiences, social, emotional, and cognitive impairment. And our show is dedicated to social and emotional well-being and discovery. Adoption of health risk behaviors. You start to see this pyramid that the ACE study has found. We have data, and we can see it from an external validity, meaning generalizability to the community, not just San Diego, we can see it throughout our nation.
throughout
the world. And yet, where's the intervention? Where's the support? And this is where, when we talk about policy, is really getting down to data-driven, evidence-based, but also having people that experience trauma that have gone through some of the paradigms to help them create resiliency, the best practice is bring them together and create policy, not this kind of bureaucratic top-down, marketplace that we were talking about early. I guess the $1 million question is, how do we get it so there's reimbursement attached sometimes,
Well, that's proving to be probably the thorniest issue of all. I mean, the good news, and there's good news here. I mean, if you look back 10, 15 years ago, people weren't talking about these issues. And we didn't have the ACE research. We didn't have the science to back up that. We didn't understand that trauma actually can shape the architecture of a child's brain, or influence their life cycle this way, or what we now what's referred to as epigenetics, the interaction between the environment and genetic makeup.
Epigenetic, yeah.
So a colleague who's actually is the immediate past president of the American Academy of Pediatrics, Bob Block, was here a few weeks ago talking to a conference that we had. And Bob, obviously, American Academy of Pediatrics is an influential group. He sees this as the biggest issue in healthcare, and over the next 10 or 15 years will become a dominant issue in everyone's mind. And so it seems really frustrating because now we have these answers and policymakers haven't taken note yet.
It makes my head explode. Yeah. I mean, I got my degree in public health, and I've worked in the field before I was even, got my master's degree, and now I'm working in social work. And, trauma to me is so prevalent, and drug and alcohol addiction. Right. There's a small percentage that have a pure genetic predisposition, but if we really look at one of the major components of addiction and substance abuse, trauma. I heard this so many times, the similar stories, or if I was doing case reviews for quality assurance where around 15, 16, family dynamic or a divorce, or there was abuse that came out and they end up using drugs, or they get into a gang. You can kind of see these trauma catalysts, I call them, where you either go to the resiliency side and overcome, or the trauma continues to be the weight that holds you back from your true opportunities. And it's so prevalent, and yet we continue to talk trauma-informed care, and and I would imagine from your perspective, sometimes you feel like you're beating your head against the wall. It gets really frustrating.
Well, yes and no.
Well, right, right.
So let me give you the yes part. It's to see such clear evidence and have the answers so clear cut that are being routinely ignored is frustrating.
Yeah.
But I'm older than you guys.
You're right. Right.
So I have more perspective.
Right.
So
hindsight.
When I got out of graduate school in 1977, the idea of protecting kids was all about get them away from the bad abuse.
Right.
Physically protect them. Then the answer got to be, well, we need to get them to a permanent home. We need to get them adopted or back with their birth family. And now the research shows us, while physically protecting is very important and getting kids to a permanent home is very important, their mental health needs don't get better because of either of those.
No, not at all.
It's true.
And the reason why I have hope is about 4 years. We started looking at trauma, and I'll tell you how I kind of got into the trauma-informed system stuff. We were working with how do you treat sexually abused children, and working with some of the people who developed the most effective evidence-based treatment interventions. Mm-hmm. They were trying to have a meeting about how to treat sexually abused kids, and people kept raising their hands and said, well, what do you do when they change foster homes? What do you do if the court orders the child to go visit the person who abused them and they're scared to death of it, and there's nothing you can do? We began to realize all this system stuff was getting in the way. Even if you had the right clinical answer, there were all these things that kept it from being effective.
Yeah.
So we started talking about what's called trauma-informed systems in child serving systems, and trauma-informed child welfare, because that was an area. The child welfare system in the country probably has a higher percentage of traumatized kids than any other system, with the possible exception of juvenile justice. And when we sat down with child welfare leaders, we couldn't get the time of day. They've got all these other priorities.
Yeah.
That has fundamentally changed. We have a grant to work with multiple states, and so we're working with multiple states, but we're getting calls from all over the country. Can you come talk to us about this? It's moved from something nobody was interested 7 years ago to something everybody wants to talk about. Now, the trick is not for it not to be the flavor of the month,
Yeah.
Or
but actually
the
be a
growth
sea
effects,
change
right.
where it actually becomes the new way of doing business.
Right.
Thank you for highlighting that too.
Thank you,
Not
yeah.
being the flavor of the month, because that's really what we're kind of seeing here. Trauma has become this big thing lately, and it's like usually when we have these big things, they go away.
Yeah, and that's what we're fighting against, because it was a big thing for us before it was a big thing for everybody
Yeah.
else, and we want it to be a big thing later. And I think you can apply, our definition, we have a formal definition of a trauma-informed system, but the simplest definition is if you look at what you're doing through a trauma lens, if you just simply think, how do I behave differently if I think about trauma? And how do I interact with this person? It changes how you perceive that. I was doing a talk up in Orange County, and there was a guy who ran a large agency up there who I'd met years ago when he was director of child welfare for Arizona, and I was in Tennessee. And he came over and said, you just explained my last 30 years of career. It's like toxic. It's like this toxic, invisible stuff
Right.
in the
Permeating,
air we
right.
breathe.
Right.
And so by getting people to think and then giving them very practical, because one thing we discovered, a lot of people are talking about trauma-informed systems, but they just say that. They talk about how important it is. They talk about some general principles, but let's get real practical.
Yeah.
And so we give examples when we do this. And, and actually tomorrow I'm getting on a plane to go to a meeting of the top trauma centers to kind of, for the week. And earlier this week I was in Redding, California. And last week I was in Napa talking about trauma, these systems. But what seems to resonate with people is when you talk about the research, you talk about the broad principles, but then you give them practical examples. You talk about the mom from Florida who told us, I think I'm getting something out of the therapist. I like the therapist, but I'm afraid of the lady at the front desk. Because when she came in, the person she had to deal with first was the person who scared her by chastising her for being late, lecturing her, doing all the things you wouldn't want to do to a trauma survivor. The same mom gave us a great example that changed actually practices here in San Diego. She said, we were in a group that San Diego was part of, but also Florida and Rhode Island, there were about 9 different places around the country trying to figure out how we can really take this trauma-informed notion and improve the prospects of a child being able to be effectively cared for, in the foster care system, within a foster home. And she said, the night you remove my child, you being the global you, you should have. I was out of control. I was so lost in drugs, I couldn't care for my child. I get that now. But the way you did it made me feel like an ant.
It's stigmatized even further.
Well, but then it goes back to your point. We should listen to the folks who've been through the system.
Yeah.
Because there was tremendous wisdom. And this lady had wisdom. And she said, had you asked me, she doesn't know the fancy science around trauma-informed systems. She just intuitively knows it. She said, had you asked me that night to tell you about my child, one is I could have told you. I could have told him how to help my child sleep better tonight. He likes the light on. What he likes to eat. What he likes to watch on TV. How to make him feel comfortable in this new place. And along the way, I would have felt like a human being. You might have and respected. Because trauma is about a loss of control. And fundamentally, whether it's a tornado or a sexual assault or a war, it's you're out of control and you're trying to gain some degree of control in the middle of this chaos, and your mind and body is spinning out of control. So every time we can work with trauma survivors and give them some degree of control and hand something back, even in an environment that's as stressful as removing a child from a home,
Right.
or removing it, that we can't make the stress go away, but we can reduce the stress.
Right, and I think even in that situation, within chaos theory, there is order, logos and eros, right? And so, if you come from love with that mother, and it was out of control. She owns that, but
By the way, kudos to that mother, because it had to have taken a lot of courage to stand up and say that.
right,
Oh, tremendous! Actually, that mom wanted to leave. We were meeting somewhere up in the east, and she was. At the end of the first day, she wanted to get on a plane and go back. She was feeling out of control, that that this place wasn't she wasn't comfortable here.
Yeah.
And, we convinced her to stay, and she turned out to be one of the most prolific, wisest people there in terms of her contribution.
Yeah.
She had to feel comfortable. She had to kind of feel like, hey, I do have the power here. And it changed. I've noticed in crisis responses like that, when the trauma is happening or has just happened and things are still elevated, a simple redirect, focus on strengths, come from an empathetic viewpoint, can really smooth the situation over a little more significantly. But there's almost like it's like a law enforcement. This is nothing against law enforcement. There's some really good, I've seen police where they do come in with empathy because they've been trained on trauma-informed care, gender responsiveness, those things. But sometimes I feel like we come in like we're the great saver and we're going to save these kids, and we're actually causing more destruction in that dynamic. Because how do you then rebuild the pieces of the family dynamic back? And how do you build trust of the system? I mean, I had to make a call recently to CPS on behalf of a client, and I remember sitting there and somebody saying, well, you don't have to call the parent. And I said, no, I have an obligation to call the parent.
Right.
This is their family. I'm not their family, and I'm actually I could be causing trauma to that family by my actions. Yeah. And also, let's deal with it as adults, and let's have the kid be part of it. Let's rebuild this. This is not a bad thing that we're calling them. There are some things that need to be addressed, but let's create a partnership with everyone involved. As soon as we start getting into don't tell this or don't do that, as soon as I hear don't, I feel like I'm doing the wrong thing just as a professional. It's what's the right thing. Ultimately, our goal is to get the family unit back together. And if that can't be, then what's our next step to make sure that we minimize any further trauma or harm to that dynamic so that we allow the future that hopefully it can be repaired. But I do see, and I was just reading some research that actually gave Donna Marto from Family Youth Roundtable some evidence-based research that talks about that very thing. Is we pull the kids out, we're not focusing on let's come in and say how can we preserve this? What are some ways and strategies to get the family system, established? And it's going to take some paradigm changes. I think organizations are starting to realize they have to have trauma-informed care from the person answering the phone. Because that first person that might be wanting to commit suicide or might be at their wit's end because of trauma, that might be their first contact. And if you come at that from that, hey, well, we got a waiting list, or we can't see you right now, or, I'm busy, I don't have time, we may have lost a life. I mean, so
And not only just that, but to touch on that, you got a lot of because here at the roundtable, when we have our councils and we hear what family and youth in the community are saying, they already got enough trauma going on with the access to care. I live in Imperial Beach. I got to go to El Cajon to go to my therapist.
Right.
And I got to take a 3-hour trolley ride and take 2 different buses and 2 different trolleys.
We cause trauma getting to the appointments.
You know what I mean? And then the first person I see, they stigmatize me or, whatever, and that just makes me not want to go no more.
And that's why I think there's hope, because there are a lot of people talking about this that weren't talking about it before.
Yeah.
I mean, and it's talking about it doesn't really change anything. You got to it's a first step.
Yeah, starting the conversation.
It's easy to do what we call paper changes. Change what you call it, change what it looks like on the letterhead.
It's still the same thing.
But changing at a performance level, at a cultural level, is where the gain really is. And that it is. I mean, the issue you just talked about. I mean, child welfare as a system and as professionals has gotten it really well in their head for 30 plus years that we shouldn't remove kids unless it's absolutely necessary. We've had interventions like home builders designed just to try and do it. People have tried all sorts of things. But day in and day out, you also have the phenomena of when cases go wrong, when they make the wrong decision, there's a relentless, the community reacts to that too.
Right.
Child welfare is one of the few places where you're not allowed to fail at all. It's like air traffic control. It's not okay to crash a plane once or twice a week.
Right, or crash a family.
Yeah.
Right.
The problem with child welfare is the only time if you know you have it right or wrong is when you have it wrong.
Right.
Fundamentally wrong.
So true.
You can do the right thing in your entire career in public child welfare. And if no child ever dies that you thought was safe, then you don't know you actually did it right. You may have actually removed kids who shouldn't have been removed. You could have caused different types of damages. So the only time you know whether you're right or wrong is if you send a child home because you think they're safe and they get killed.
Right.
And then the world comes down on your head for how could you do that when the political leaders should be asking, how do we set up a system to try and support people so that doesn't happen again, as opposed to let's find somebody to blame.
Well, again, it's rhetoric. It's a way
Yeah.
to pull away from the true need and focus on that one or two cases. But I also think that one of the things that I see in all systems when they come social service and behavioral health is that the vicarious trauma that happens to the worker and the bureaucratic, like we all get into this field to make change and help people, but then some of the bureaucratic realities happen, the hierarchical structures that we have to work within, and then the constant trauma of constantly seeing these things over again and knowing data, knowing what's needed, but not having the right tools in your toolbox sometimes as that worker to actually make the right intervention.
Or to address the vicarious trauma.
Or the vicarious trauma, right.
When we talk about trauma-informed systems, we're talking about recognizing and responding to what really is going on physiologically and emotionally with traumatic stress in children, in their families, and in the workforce.
And the workforce. That's beautiful.
And there's a fair amount of effort around what's called secondary traumatic stress or vicarious trauma. In fact, as I told you before we started the show, we had about 2,000 people from 38 countries here a few weeks ago at the end of January at the international conference. We've been doing it for 28 years. In the 29th year, next year, we're going to have a sub-symposium on secondary traumatic stress, bringing in a think tank with the top kind of researchers and thinkers in that area, because there's a growing recognition of if the trauma is like a toxic substance. Not only does it affect the people that were traumatized in the original events, but everybody who handles that experience, who hears about it, who sees it, witnesses it. I'm married to a former child abuse cop, and she still has nightmares about cases that she worked 15, 20 years ago.
They don't leave.
Last time I was a frontline clinical person or professional or child protective service worker was in the 1970s. And I still have vivid memories of certain kids that don't leave you.
No.
But it's a mix of how you then respond to it, because you got really two issues. You've got the secondary traumatic stress, but you have the overlay of burnout.
Burnout, yeah.
The organizational things you talk about, you could be working in a widget factory and have burnout.
Right.
From crazy rules of bureaucracy, stressful bosses, workload productivity demands, relentless pressure. Layer on top of that, trauma. I have some therapists who've been trauma specialists with us for 22 years. And on a busy day, they'll go down the hall, they'll meet a child and family in a weight room, bring the child in hand back to their office, descend into that child's little corner of hell to help them deal with what they experienced, and then bring them back to the surface so they can go on about their day. And back out and sit down with mom, talk for a minute, and then they go on, and then they take the next child and go back in, and they'll do that 1, 2, 3, 4, 5, 6, 7, 8 times in a day. There's no way you could do that and go home at night and not have that haunting your dreams and haunting your own family and your own worldview.
Which brings me to a very, and forgive me if it is off topic, but what do you do and what do you tell your staff and your wife too? Like, how do you deal? What is self-care for you? Trauma is.
We were talking about this before the first interview. I was I had a colleague call me, and the things that they were talking about, I said, "You're not using the tools that you tell your clients to use.
Right.
Close your eyes and tell me what you would do." And at first there was bias, and then finally she said, "Well, I would do some guided meditation." I said, "Then do it." And then I got 10,000 excuses of why she couldn't. And I said, "Well, how often have you offered that to clients recently?" And then she told me, I said, "Okay, then when was the last time you did it?" And she had to think. And then it was like, because it's so hard for you to do right now, think about what it's like for the people we're serving.
Yeah.
And if you can't do it, what do you expect them to do? And you get upset when they don't. So let's come full circle about this. Fix yourself right now. Because what I'm hearing is you're at a bad place. And I think a lot of it's because it's an internship and termination is happening. and there's some emotional components going on. I also, as I called it in our last interview, and I talk about this a lot, when you're in graduate school, there's this thing called school-inflicted trauma disorder. And so you can see, you know it, right? I've defined this, and I say it satirically and kind of funny, but it really is. You're not social anymore. You become isolated. You don't know how to socialize sometimes because you're taking in all this information, and it's hard to have a normal conversation. And then how many people get divorced or separated or abuse happens when you're in school, or neglect, and yet it's happening, and we're trying to educate ourselves to be these helpers, but yet we're under this condition of trauma, like.
See, but you let people know in advance, like, hey, finals are coming up this week.
Yeah,
Don't even call my phone.
Yeah, but I've learned my triggers, and I've also learned how I have to let my social network know. But I'm also pretty open about my own personal traumas too, and how sometimes my impulse control issues are related to that still to this day. You know.
But going back to the question is, like, trauma can be such a horrible thing to have to deal with 8 hours a day, 12, 7 days a week, every single day of the career. How do you keep yourself grounded? How do you keep yourself going? How do you keep yourself rejuvenated for this in the next day?
Your wellness recovery.
Well, I think every individual finds their own path is one.
Right.
And their own resiliency and their own ability to tolerate. Now, there's got to be an individual response. So we can talk about that, because that's normally what people talk about. What we're searching for is how do organizations do a better job, because it's a pretty cheap answer, and I don't have a really good answer right now. But I direct an agency. I've got people who do this type of work. They're doctors who deal with this. They're interviewers who hear the raw stories.
Yeah.
Excuse me. There are.
Would you like a glass of water?
Yeah, that probably would help. And so, how can an organization be more effective? I know we work with New York City trauma program at NYU, and they developed an intervention they're testing out in New York City, which is essentially a more structured way of what happens in good trauma programs in general, which is peers helping peers. So if you ask the therapists at the Chadwick Center what's their best way, it's a hallway conversation, debriefing with their colleague who kind of knows their world.
Right.
And they can share, and kind of ventilation is kind of good for the soul.
It is.
Mix that with some balance in their life.
Right.
I mean, the biggest reason we lose therapists is to private practices, because in private practice they don't have to be a trauma specialist. They can take
and they provide good clinical supervision a lot of times.
Unhappy housewives and all this other stuff. In our place, we specialize in trauma. And when we talk about should we not specialize in trauma, nobody wants to do that. There's pride in being a trauma specialist.
There is.
But it's hard to do it day in and day out. And we actually we have an hour of individual and an hour of group supervision every week. And the group supervision often is about dealing with issues of countertransference and all the stresses, how people are dealing not just with their cases, but how it's affecting how they're viewing their cases.
Right. And one of the things that I see that concerns me about the supervision process, and again, it's where I guess one of the things that we advocate for is show your scars, no matter where you're at. In business, it's so hard when you're working within a profession to say, you know what, that case really, I took home, and this is how I took it home, and I didn't handle it well. Like, those are things that you might know about somebody, but we never bring it to the surface like we would in a group, right? But I think as professionals, it's important that we have to realize that I call it kick the dog syndrome. You take things home and there's an outcome sometimes that you don't want to have, but you do. But we're afraid sometimes in that group supervision process to really actually say that or talk about, you know what, here's what I'm struggling with right now. I don't know if it's an ego thing or it's just we don't, that's not what we talk about at work. I think that's changing in society in general. One of the things about recovery and trauma recovery is we always think that ours is worse than anyone else's until we hear somebody's story. And then it changes the whole dynamic so significantly that we're like, man, why didn't we have that conversation sooner? Why didn't we talk about these things? Why was I holding on to this so significantly? We had a gentleman, Scott Silverman, that comes on the show periodically, and he started Second Chance. And one of the things that he's trying to start is to work with EAP programs for those professionals to actually provide that support when addiction becomes the issue. There's not really a support. And what he actually went to like local police departments, law enforcement, and other entities and found out they really didn't have like a trauma EAP program to help deal with the things you just talked about.
I think a lot of organizations, that's the answer they get. Well, we have an EAP program.
We have an EAP, right?
And you have a particularly high-profile, high-stress event. You know, work at a hospital. That happens. I mean, you get 3 or 4 kids in fatal car accidents who die in our ED in a 48-hour period. For hardened ED nurses and trauma surgeons, it's devastating. And then if our answer is, well, let's have somebody from EAP come, you know, who's available on short notice, who's an EAP provider who can be there tomorrow? The person who doesn't have enough patience to keep them busy.
Right. Yeah. Or takes the lowest rate, right? Like we talked about earlier.
Yeah. Right. So EAP often has not been helpful in lots of people's experience because you need someone who really understands the issues you're dealing with. So we actually, in our hospital, have 3 or 4 people who have been very effective at helping people kind of process those kind of peak horrific events. The problem is, you know, we can recognize when we have like multiple deaths that impact on the ED, or a child who's been cared for in another unit for with a chronic disease that everyone's coming very close to, and all of a sudden the child. Yeah, we can respond to those, but it's the day-to-day, day in and day out, seeing, feeling, touching the pain. And then if you had pains like that in your life, in your childhood, if it's, you know, you can do this type of work and work with abused kids, but then you run this kid that reminds them of your situation or what happened to your brother, and or you're doing fine, but you know the trauma doc that walked into the room and the child laying on the table is the same age, same size, same stature as his 6-year-old, and looks like his 6-year-old, and he's got to stop and do that. And as soon as he finishes trying to save that child, he has to walk in the room and walk in the next one. Yeah. And it's really hard stuff. For trauma therapists, you know, they can, you know, they child after child, but there's something about that child that kind of gets in their soul a little bit, or triggers something. So it's really hard stuff. We ask people to work with this toxic
we're going to put you in a very mentally toxic environment.
And we're going to ask you to do and perform at very high levels because, going back to your point, because reimbursements are so terrible, we have to ask you just to keep the lights on. You know, we have to worry about productivity and seeing enough patients, generating enough revenue to be able to keep seeing patients. But the volume of doing that just raises the burnout in the trauma process. So it's a challenge. I haven't quite figured out the answer to.
Yeah, and see, I'm sorry, Nathan. Years ago, I had my first child at a very young age, and because back, you know, I guess you could say in my previous life, or you know, a few years back, there was drug addiction, all kinds of different things that I was coming away from. When I was 19 years old and my son was born, I asked myself, like, what would your legacy be? And I didn't, or what would people say about you if you were to die tomorrow? And I did not like the answers I was getting. And then just being so open and honest with the hospital and everything, CPS ended up getting involved in our lives. We had to go through what normal people would have, like a 2-year or a 6-month child welfare case. Ours went over like 3 or 4 years. Because after, you know, there was bipolar and schizophrenia on the mother of the child. I mean, there was all kinds of different things. Challenges. And one of the workers, we had a lot. One of the workers we had, she was a brand new to the industry, came from Berkeley, and to this day, her name's Stephanie. She was the best social worker we've ever had, but she quit. And she quit in the middle of our case, and she came and actually told our family, I'm quitting because I can't get personal with my families. I'm supposed to just do what I'm supposed to do, and I'm not allowed to like see them for who they are or whatever. It's all by a book, and the book doesn't have the answers to everybody's different culture, different things. And in 4 months, because we were one of her first families, in 4 months being here in San Diego, fresh from college, burnt out, quit. This isn't what I got into this for. Like I got into this, like you were alluding to earlier, to change the system, to help people, to do this stuff, and I don't see this as the position to help me do that. And I remember my mother, who was there, she's pretty pretty well endowed inside of the mental health industry. She had no answers for her, and trauma at that time, not to say anything, but it wasn't the flavor of the month. So there wasn't anything that we really knew firsthand. Here's how you deal with this. And you just reminded me of that right now when you were talking about the burnout. And I was like, oh man, Stephanie, because she was such a great person. And one of the only social workers that when I met with her, she didn't go like this and look at my juvenile record and judge me by that before she had a chance to actually meet me. She basically threw the book out the window and said, who are you? And asked me questions that I didn't realize. So I loved that about her, and it was just unfortunate that she couldn't carry on in this type of industry because she would have done great.
Well, and the Stephanies of the world could reshape that industry.
Oh, yeah.
And so the double loss, it's a loss for your family, but it's also a loss because if in fact she cared and she could see the nuances of what she was looking at, the trick is how do you figure out how to bottle that and spread that, and you have to stay in the system long enough to have influence to shape the system.
Totally agree.
As bad as it is, in 1972 when I started, it was much more rigid, much more controlled, and I'd like to think we've made some improvements. But it's got a long way to go.
I can imagine.
Well, it does. I think, we were talking for the preliminary interview, one of the big issues is reimbursement. Yeah. So one of the biggest issues is reimbursement. I think when we talk about policy changes and I don't know how this is going to happen. We're talking about integration with the Affordable Care Act, but we still haven't seen it actually really fully implemented. A lot of people don't even know what it looks like. And then when we talk about reimbursement, was it something that you said in the preliminary that sticks out is, okay, we could do all this work, or maybe the kid just needs a baseball team, but you don't get paid for that. But we might, by interacting in those family systems or with the traumas that are happening, we may say, well, you know what, they don't need that pill and that diagnosis. They need this, something that's a social component where they feel like they're part of something. And that has such a societal impact long term. It has ability for that person to get functional and back on track, so they're a contributing member of society. But when it comes to reimbursement, that's so subjective based on the billing mechanisms. So then they do grants. The problem with grants is you have to have so many people to justify it. Or something else you said, we end up with waiting lists. So we know with waiting lists there's a need. But again, I think this is where when we start talking about functional policy, we've got to look at, let's get away from some of the medical model stuff that doesn't work in behavioral health and social services, and let's talk about what's functional. And maybe it means adjusting how we go about it. I think one of the things in policy that happened in the 80s was these waivers, these Medi-Cal waivers. I still think, and I think insurance could work like this. If this is a trauma issue, you would come with a pot of money that would be attached to you for those service needs. The goal is so that you don't need those service needs, so they go down, and then you can spend them on other services that are needed based on your self-determination within the biopsychosocial system. I think those are real conversations. But we're going to have you back on to talk about that. Cause
we need to get you back on.
Because I know you have to get to something, but I really wanted to talk to you about the work that you're doing with kids, because it's so important. I've had a few cases recently where there was some pretty horrific traumas, and we could do all the work in the hospital, but not having the transitional piece in the community was so significant, and it breaks my heart, because I know those kids are either going to come back or worse, because they don't have those transitional supports in the community. So, talk to us about what you're doing with kids and kind of some of the findings or the work that you're seeing in trauma as with families too.
Well, first, make a point that treating children for trauma in the absence of working with their family or their caregivers is not a good use of anybody's time, including
Right.
the child's point of view. I mean, so a therapist that wants to play Uno with a child once a week for the next 6 months and call that therapy is probably not. It's actually appalling, because there's a window of opportunity when a child goes into a therapy session that maybe we can help them. And with the ACE research, the Adverse Child Experience research, maybe we can change a life trajectory that doesn't have that child still being haunted by those same images, those same nightmares, or having it occur on this physiological level that the child, the now adult, doesn't even recognize that their response to a bright light has to do with the trauma. They just know they freak out when they get that. There's an opportunity there. So getting good clinical intervention is very important to us. So we have people who specialize in childhood trauma who, a number of them have been doing it a long time. We use variations of therapy models that have been demonstrated to be effective, that can show that they can get the symptoms, nightmares, to go away. We actually do a fair amount of assessment at the Chadwick Center. So when a child comes in, we learn a lot about them before we decide what our therapy approach is going to be. And some of that we're using standardized clinical measures, but we can actually see nightmares starting to go away after about 3 or 4 months, and the child's starting to make real gains. So we use, there's these things called evidence-based practices, which have research to support them. One of the things that we do at the Chadwick Center is we run something called the California Evidence-Based Clearinghouse that looks at what's the science behind things that people are using with kids who've been exposed to abuse and neglect. It's a web-based resource that anybody can go use. It's www.cebc, the number 4 CW. So CBC 4 CW, because it's paid for by the state, funded by the state of California's child welfare system. But in looking at that, we find there are some things that really do work, and we find some flaky things that probably haven't been tested, and there's no real reason to think they do work, but people are out there selling it.
Yeah.
And adults tend to be afraid, particularly even mental health professionals, tend to be afraid of talking about trauma. The kids aren't.
No, the kids are not.
Yeah.
In fact, they're so open about it, it kind of freaks you out sometimes.
But when you start trying to talk about this with adults, it freaks them out.
Yeah.
And so a lot of mental health practitioners aren't comfortable with trauma. They'll take trauma patients because if they didn't take trauma patients, who would they be seeing?
Yeah.
But they don't like to deal with it. And probably, I do have to run, but I'll leave you with a story of a colleague of mine, Esther Devlinger in New Jersey. Esther's a trauma specialist who actually is one of the developers of trauma-focused cognitive behavioral therapy, which is one of the interventions with the strongest research base. But there was a child being seen in the community by another psychologist after being sexually assaulted by her father repeatedly. And after a year or so, was still having nightmares, just couldn't get the issues out of her head. And so her mother, talking to the psychologist, said, "It's not working. What do you think we should do?" And he said, "Well, I don't know. Maybe we should try that. Go see the trauma lady." So Esther met with this young lady and began, starting to get to know her. Said, "Well, I saw you were meeting with Dr. King a lot over the last year. So what did you talk with Dr. King about?" "Well, we talked about school, and we talked about me and Mom. We talked about my boyfriend, and when I got upset." And Esther said, "Did you ever talk about what happened with your dad?" And the little girl leaned forward and said, "He wasn't ready for it."
Oh, man.
He being the therapist.
Yeah, that's...
I had a case like that recently.
That's
And,
intense.
I routinely, even now, one of the things we're working on is a process called doing screening for kids. Screening which kids really need mental health interventions and which need a trauma-specific intervention. And screening is a form of a set of kind of very short-term triage to figure out who needs to go see which
which
person.
one's a priority. Right.
Setting the priority. And child welfare workers can screen, emergency room people could screen, nurses could screen. But we run into people routinely who said, "Well, they can't ask those questions. They can't ask kids about whether they have nightmares or intrusive thoughts. It'll remind them of the trauma, and they'll be upset. So, we can't do that. Only a mental health person should do that. No, they don't get to the mental health person unless somebody who's not a mental health person takes them there, and they can't take them there unless you kind of systematically figure out who needs to go where.
Yeah.
And it's not the kids that have the problem; it's the adults.
No, it's funny because nurses that are trained in trauma-informed care, they're amazing, and they're usually the front lines in identifying it. I've seen time and time again where we'll do we'll look at diagnosis and all this stuff, and then nobody's looked at the trauma, but there'll be a nurse in a meeting that says, wait, we didn't see this patient until such and such time. What are we doing for that? And you're right, even doing suicide assessments in a hospital, low, because nobody wants to deal if it's moderate or high. So I think there's a lot of truth. I know there's truth to what you're saying, and I know that your message is so needed out there.
Definitely, and that's why, Mr. Wilson, in my last question, and I promise we'll be done for today.
I know, until the next time. Here hostage all
yeah,
day
because this is something that it kind of touches home for me. Just one last question before we let you go. How do we, in your opinion, not let trauma-informed care just become this thing of the month? How do we keep it going? Keep people interested in advocate.
We're actually trying to figure that out too, and I'll tell you what. One of the grants, in fact, the grant I'm going to Washington on, we're working with Daytona Beach, Florida, state of Rhode Island, 4 counties in southern Minnesota, Custer County, rural Oklahoma, San Diego, and Orange County, asking how do you basically infuse it in the cultures of the systems. And the way you change, it's really about culture change, organizational culture change, system change. Culture is that we do when no one's looking.
Right.
It's just the kind of the default thing. It's how things work around here. As long as it's seen as a project, it's not business as usual. You want to make this where it's business as usual. And so organizationally, it's figuring out what are those points of influence? What makes things change? Now, it's policy and it's training, but if that's all it is, that's just process change. How do you get leaders to perceive the change? And when I use the word leader, I don't necessarily mean the director.
Yeah.
No, the interdependent
the leader who's the leader in the office at the water cooler. It could be the lady at the front desk. There was a great little book years ago that looked at how things change, Malcolm Gladwell's book. And it's, one of the things in looking at how pieces change is, finding those people who know more than their average share of people, who speak their opinion and influence those kind of mavens in society, and get them embracing this. Because we're successful in it not being the flavor of when we stop doing it to do it. Because we're just doing it.
Yeah, it
exactly.
becomes what we do. It's a fabric.
And then it's really hard for the next person to come along and screw it up because it's how
it's just
it's
business
now
as usual.
culture, right? Oh, it's so beautiful.
Thank you so much for a powerful interview today. Truly appreciate your time, Mr.
Sorry
Wilson.
to run.
Oh no, you're fine.
We're
definitely going to be at your Cynthia, their name,
Yeah,
correct?
Cindy.
We're going to be telling her we need you again. Give us some dates. Thank you so much, and tink you everybody who joined us on Ustream.
That was Charles Wilson from the Chadwick Center, part of Rady's Children's Hospital.
Love it. Thank you guys.
You guys mind if I run?
No, you're fine. You're fine. We got the picture beforehand.
They're 5 o'clock. All right, thank you guys.
Yeah,
thank you, sir.
Thank you very much. It's so funny because, some of the stuff you're talking about, we do.